We are starting today with Ms. Ann Langley, who is the Director of the Center for Population Health Initiatives at the Maryland Department of Health. In this role, she helps Maryland achieve specific population health improvement goals with an initial emphasis on diabetes. Prior to joining MDH, Ann served as the Senior Director of the Health Planning and Community Engagement at Johns Hopkins Medicine. Also with her is Dr. Sadie Peters. She is the Medical Director in the Center for Population Health Initiatives at the Department of Health. She's an internist who spent 8 years in clinical work at Johns Hopkins Community Physicians before joining the public health sector. Dr. Peters is very interested in innovative interventions that expand population-level preventive health and the management of chronic diseases like diabetes and cardiovascular disease. So welcome again. Don't forget to use the chat. And Ann and Sadie, if you will turn on your microphones. Thank you.
Okay, sorry, took me a second. Hi, thank you for the introduction, Sue. I'm Ann Langley, Director of the Center for Population Health Initiatives, as Sue said, and I'm really happy to be here and appreciate you all joining us. This is this series of 8 webinars that we've been engaged in, 3 of them here on the MDPCP schedule, is really one of the first steps that we've taken since I joined the center 6 months ago. And there will be more like this. And I really appreciate your feedback at the end of the session about other things that we can do that would be helpful. Okay. So I don't know how to advance these. There we go. This is real quick. I know that you all are very familiar with the impact of diabetes. I learned more specifically about it when I joined the center. 2.1 million adults in Maryland with diabetes or pre-diabetes. That's about 1/3 of the population of Maryland. Of the 1.6 million with pre-diabetes, 90% don't know it. 6th leading cause of death and a contributing factor to other deadly diseases. And the costs, loss of productivity, 4.9 billion in estimated annual medical costs, much higher costs for people with diabetes than without. Next slide, please. Thank you. So there's really a lot of information and facts in the Diabetes Action Plan. We chose just this one graph to illustrate that not only of the large impact of diabetes, but the disparate impact on different populations. This graph illustrating the differential impact by race. There's also a geographic difference across the state and others, but I just wanted to emphasize that. The next slide. So the Diabetes Action Plan, hopefully you're already familiar with it. It was produced over the course of 2019 and released late last fall by the Maryland Department of Health. It is full of information and a call to action, and the call to action across different groups. And I wanted to highlight today that as a resource. There are lots of different partners that are named in the plan that are have a very important part to play in helping you all do your work, helping your patients manage their diabetes, prevent diabetes, manage their health. And the link to the plan is there, and I encourage you to look to that at some point. You know, I know that it takes, diabetes is as true of many diseases, but in particular, I believe, this is not a problem that the healthcare system can solve by itself. Next slide. And with that, I'm going to turn it over to Dr. Sadie Peters.
Hello, everybody. And again, thank you for being part of this conversation with us and allowing us to be here with you today. I think the slides, are they still there? I wanted to talk a little bit about Dsmes, diabetes self-management education. So national standards, including guidelines from the American Diabetes Association, indicate that all people with diabetes should participate in diabetes self-management education. It gives people with diabetes the knowledge, the skills, and the ability that's necessary really for effective diabetes self-care. DSMES is a 10-hour program facilitated by diabetes educators. You'll hear more about it as a little later on in the webinar today. But it is facilitated by diabetes educators, nurses, and pharmacists, and it has a curriculum which may be delivered to groups or to individuals. It includes education about nutrition and physical activity, some problem solving for better health, education about treatment options, medication use, and prevention, detection, and the treatment of acute and chronic complications. There is plenty of evidence in the literature demonstrating that diabetes self-management education and supports is extremely useful, actually, to patients. It improves health outcomes as well as it actually helps to reduce costs. So it's associated with a lower hemoglobin A1C, lower cholesterol and blood pressure levels, better medication adherence. Patients report better quality of life and improved weight control. Research shows that it's associated with reduced all-cause mortality risk. And DSMES is also associated with improved use of primary care and preventive services. However, although it packs a lot of benefits, it's extremely underutilized. So only 6.8% of people with type 2 diabetes who actually have health insurance enroll and get or use their DSME benefit in the first 12 months after their diabetes diagnosis. And for Medicare patients, that taking advantage of DSME is even lower. So this shouldn't be. It's a resource, it's evidence-based, and it should be used. So I really would like to encourage everyone to sort of take a look at what the barriers might be in your practice to using DSME. And you'll have a lot more information a little bit later on in the webinar about how to make sure that you're maximizing reimbursement for this. So next slide, please. So DSME, as I said, is delivered by trained diabetes educators. They're professionals who help to support diabetes self-care behaviors and problem solving and encourage active collaboration with the healthcare team. It should be an ongoing activity that's actually part of the lifespan of someone with diabetes rather than just in the first couple of years after their diagnosis. And there are 4 critical times that DSME should be used. These are at the time of diagnosis, annually, to assess for patient knowledge and nutrition and emotional needs. It should also be offered when there are complicating factors that arise that might actually influence self-management. Say someone has worsening cataracts and is having trouble reading their medication, that might be a good time to offer DSME again. And then when transitions in care occur, like the move from a family home to a nursing home, for instance, might necessitate DSMES. Next slide, please. So This map shows the location of the DSME providers in Maryland, the programs that offer DSMES. It also shows that there are significant gaps in the provision of these programs. The Maryland Department of Health is working to fill these gaps and to bring more program providers on board so that it's more available to people who need it. But what's also really good is, and you'll hear, I think, a little bit more about this a little bit later on, is that during this current national emergency with the COVID pandemic, there is more opportunity now to use distance learning to help provide this kind of a program. Next slide, please. This is a screenshot of the Be Healthy Maryland website where DSME program providers may advertise their classes and where healthcare providers and teams can help their patients find a class. The website also has links to other resources that could be useful for diabetes management and prevention as well. Once a person with diabetes has had intensive self-management education, it's really helpful if they have ongoing support and reinforcement of that education, and there are diabetes self-management programs of all sorts, and many of them are evidence-based and well-supported by organizations that do this in the community. And some of these classes are taught by lay educators. They're more informal and they really rely on peer support to help individuals reach their goals and sustain good habits. This website also helps you locate some of those programs, and the ones that are on Be Healthy Maryland are evidence-based programs that will help patients with their ongoing education. Next slide, please. There are additional resources about DSMES, and these can be found on the website for the Association of Diabetes Care and Education Specialists. This organization used to be known as AADE, the American Association of Diabetes Educators. They had a rebranding in January, so that the name here may not be familiar, but they have been around for a long time. This is also the organization that credentials diabetes educators and programs and helps set the national standards for diabetes education across the country. Among the links on here, and you'll see over on the left, a little bit hard to see probably, among the links across the top of their homepage is one that can be used for patients that helps to explain why diabetes self-management education and supports might be beneficial for them. There are also a lot of resources for patients who speak Spanish as their primary language on this website. So I just want to leave you with a plea to please encourage your colleagues to refer people with diabetes to DSMES through the patient's life course. Again, it's extremely underutilized, but it is an evidence-based program. It's effective, and it's part of the standards of care. Sue, back to you.
Thanks very much, Dr. Peters and Ms. Langley, and we are going to move forward into our next presentation, which is going to be by Dr. Mark Rabner. He is the head of clinical applications at CRISP, the Chesapeake Regional Information System for Patients. Hopefully all of you are very familiar with CRISP. He is an attending physician at Children's Hospital of Philadelphia, where he leads a multidisciplinary team of healthcare professionals in evidence-based diagnosis, treatment, and coordination of care of hospitalized and often medically complex children. So Dr. Rabner, please take it away. You can unmute your mic.
Hi, everybody. Thanks for the introduction and inviting me to present here. A little bit of a change of trajectory. We're just going to talk about some tools that CRISP has to support you in diabetes management. Great. So since we are coming from different places, I just wanted to level set with everyone about what CRISP is and some of the tools that we have. And so you likely know CRISP from its role in hosting PDMP, but we are the region's health information exchange and serve Maryland, West Virginia, and the District of Columbia. We have data in CRISP from many different sources. In Maryland, we have every acute care hospital in the state is sending us data, and we're sending them data. We have many long-term care facilities, many ambulatory practices as well. We have about over 18 million patients in our index to be able to be searched, and hundreds of thousands of searches occur per month for patient information. And you can interact with CRISP in a few different ways. CRISP is a panel-based system, so we rely on practices and health systems to send us panels of their patients, and then from those panels, we're able to, when you search for those patients, you're able to access their CRISP record. The first screen I'm showing here is called the In Context app. Some of you may be familiar with this, and based on your electronic health record, you may have access to the In Context app, but it's this panel that lives on the side of your EHR and can automatically pull up patients' charts based on which chart you're in the electronic health record. We deliver nearly 1.5 million pieces of data per week through this method. So it's increasingly utilized as different EHRs are taking this on. You also may be familiar with the unified landing page. This is our web-based portal where you can log on either through your electronic health record or through the CRISP website. And for most of this presentation, I'll just be showing examples from the unified landing page, but all the information that you find in the unified landing page can also be found in the In Context app. We also have encounter notification services, which are push notifications that are modifiable based on defined populations and triggering events. So you can get real-time alerts based on various different events, and I'll talk a little bit in more detail about this later on, but various different ways of delivering this information and receiving these alerts. We also have CRISP reporting services and pre-post reports, which is a reporting and analytic platform that can be used with your patient panels. And again, I'll talk about this again soon. But for the remainder of this presentation, I'll just use this diabetes use case to exemplify what ways you can use CRISP to improve your management of patients with diabetes. So I'm a primary care physician. I'm seeing a new patient with diabetes and CHF after a recent hospitalization for a CHF exacerbation. She's unknown to my practice. In addition to her CHF management, I want to provide her with high quality diabetes care that is consistent with her prior treatment and improves care coordination with the rest of her care team. And so I'll be using that as an example throughout the rest of the tools. There's a lot of tools that CRISP has, and I'll go through these. I just want to set the stage that we have tools that are usable today by you and your practices. And we also are always interested in having further conversations about what additional tools could be developed to support your patients. All we want to do at CRISP is really support people that are using CRISP and physicians and practices in their management of their patients. So I'm just going to run through a few of the tools that we have today. Right now, we have encounters, which you can see in this red box on the unified landing page. And these encounters help you visualize how patients have interacted with the healthcare system. We have information on inpatient stays, ED visits, even transportation by EMS, outpatient visits, and some community-based organizations as well. So you can see how frequently or infrequently the patient may be interacting with the healthcare system. We also have health records, and you can see this small red box at the top is how you can access health records. And there you can see information about documents and lab data. For documents, for a new patient that you haven't seen before, it might be helpful to review their discharge summaries from their recent hospitalizations, and some provider notes that are provided by some ambulatory and specialty practices. You're also able to access lab data. So we get lab feeds from all of the acute care hospitals, so meaning we get all the lab data from those hospitals. We also have a relationship with LabCorp and Quest to be able to pull in data from those sources. And so if you're working within a small practice or have a new patient that has been seen outside of your practice that does not share the same electronic health record, you're able to pull up these documents within CRISP. And the lab feed also has a search feature. So if you want to, for example, trends of patients' hemoglobin A1Cs over the last year or two, you should be able to do that by searching for and pulling up those labs. We also have care alerts. And so for those that are less familiar with care alerts are vital pieces of information that really live above the patient's chart that are communicated to the entire care team. You can access care alerts through the In Context app or the web-based portal. This actually image on this slide is from the In Context app, but the box on the prior slide showed the care alerts. You can see from these examples of COVID, seeing that the patient tested positive for COVID, or this second example of a patient and their baseline exam and imaging findings, so that this lives above the patient's chart, can be easily accessible, you don't have to go digging, and can help with care coordination for those that are writing alerts and those that are reading them. There's a few ways to write alerts. If you're an Epic user, there's a special template within Epic that pushes the information that's written in that template directly into CRISP. If you're a non-Epic user, I talked at the beginning of this presentation about the panel-based system. And so you can use and enter care alert information, a brief sentence or two about your patient within that panel, and that'll populate within CRISP for any member of the care team taking care of that patient. Coming soon are to be some pre-diabetes alerts where we're working with Medicaid and Maryland Department of Health to help identify patients that have pre-diabetes based on their prior labs and prior diagnoses. We also have care teams, which live in this red box at the bottom right of this screen here. And care teams are based on those panels that I mentioned. So if practice or clinician submits their panels, the clinician or practice's information will show up in the care team. So you can identify, for example, here, diabetes prevention programs. Coming soon will be more and more diabetes prevention programs submitting panels to let you know if a patient is being seen in the diabetes prevention program. Similarly, you can see primary care doctors, specialists, as long as those individuals are submitting patient panels. And their information and contact information will appear in CRISP and be accessible. Next, we have ENS alerts. There's various different ways of receiving ENS alerts. The example I'll show you is called Prompt, which populates directly into CRISP. But you can also receive it through a direct email, through text, through database, and so lots of different ways. But this example is showing you what this might look like in CRISP, where you set up your alert, your push notification, to be notified when a patient of a particular definition. So maybe it's a patient that's been hospitalized in the last that's been recently hospitalized or recently discharged. And so those patients will show up in this left panel. And then when you click on that patient, their details will show up in the right panel. The alerts we have available kind of next day once you sign up for the Enf Alerts, if you're not signed up already, are things like admission, discharge, and transfer alerts from visits to inpatient, outpatient, ED, or OB stays. These are real-time alerts, can be sent through all those different means that I described before, but also we have a Doc Halo, which is a secure texting system to receive alerts in real time. You'll also be able to see what their utilization has been over the last 6 months, how frequently they've visited the emergency department or been hospitalized. We also have COVID results immediately available. There are some other features that through these push notifications that can be modified, and you would need to work with CRISP to set these up. But they basically can trigger these notifications based on various different events. So you can basically configure these alerts to be, I only want to be notified when a patient with a previous diagnosis of diabetes visits the emergency department for the second time in 6 months. Or I want to know when a primary diagnosis of hypoglycemia from any of my patients that present to the emergency department. So it's really infinitely configurable. It just takes a little bit of work to configure it, but happy to have those conversations at a future time. Next, I'll just mention briefly about pre-post reports. Pre-post reports uses data from the HSCRC case mix, so hospital data, to talk and present information about cost and utilization for patients on your panel. So if, for example, you have an intensive case management program for patients with diabetes, you can submit just that panel of patients and the start date of their case management, and you can see the utilization and cost before and after they were started in that case management program. And so that's the tools we have today. For the future, we have are always interested, as I said at the outset, in having conversations about how we can better support patients with diabetes and the clinicians who care for them. So I'll leave you with this questions of what ideas do you have that you would want to see within CRISP that would have the most impact. I'm always interested in hearing your thoughts and coming up with creative solutions.
Terrific. That's really wonderful, Dr. Rabner. Thank you so much. And really, it was a question or a request from Maryland Primary Care Program to learn a little bit more about CRISP. So I think this information is really critical. Hopefully, we can continue to share it with all of the members in a very real way. So thank you for that. And our next speaker is Mr. Tim Mcneil. He is the founder of Freedman's Health, a Washington, D.C. healthcare consulting firm specializing in the implementation of innovative models of care. Mr. Mcneil has led the firm's consulting efforts, serving customers including the U.S. Department of Health and Human Services, the U.S. Administration on Community Living, and is also consultant for the Maryland Department of Health. All right, Mr. Mcneil, take it away. Unmute your phone, please.
Thank you so much. So as was stated by Dr. Peters, that during the pandemic, there's been an expansion of opportunities to provide diabetes self-management through telehealth means. But that doesn't negate the basic benefit of diabetes self-management that is covered as a benefit for anyone with a known diagnosis of diabetes. In addition to that, they have a benefit of medical nutrition therapy. As many times as stated, that's a 10-hour benefit. However, every year, the beneficiary is eligible for an additional 2 hours of diabetes self-management education and an additional 2 hours of medical nutrition therapy for a total of 4 hours of educations on the books at all times for someone with diabetes. But again, as was stated by Dr. Peters, that the vast majority of beneficiaries never receive even the basic 10-hour benefit. But during the pandemic, there was an expansion of telehealth. Okay, there we go. And So that expansion of telehealth includes the provision of diabetes self-management education in the home. So during the duration of the public health emergency for the pandemic, the beneficiary can be in their home and the clinician can be in their respective home, and the services can be billed just as if they were delivered face-to-face. In addition to the diabetes self-management and medical nutrition therapy expansion of telehealth, there was also a recognition that many beneficiaries may not have broadband access. So traditional two-way audio and visual connections that are required for telehealth may not be possible. So CMS came out with an additional provision that allowed for audio only when video was not available. So again, you could provide audio only diabetes self-management education through an accredited program. You would still bill that as if it was a face-to-face intervention. Here's a listing of some of the codes, a selection of the codes that were expanded as and available to be delivered via telehealth for the duration of the public health emergency. You see that medical nutrition therapy and diabetes self-management education are on there. You also see other things that align well with a comprehensive diabetes education program and outreach. So things such as annual wellness visits. Depression is something that's common for persons that, as a comorbidity for persons that have diabetes. So depression screening, also something that can be delivered via telehealth. So the Office of the Inspector General also provided a waiver to providers to allow the delivery of telehealth even through means that are not HIPAA compliant. And so those things such as FaceTime is an acceptable method to deliver a telehealth intervention such as diabetes education, medical nutrition therapy, and this will remain in place also for the duration of the public health emergency. So you see that there's many restrictions have been removed to allow for broad adoption of diabetes education and medical nutrition therapy for any beneficiary in need. Here's a listing of HIPAA compliant telehealth models. And as I said, the Office of the Inspector General has lifted the restrictions that allows for the delivery of a education model that is delivered without a HIPAA compliant version. But here are a listing of some that are HIPAA compliant. So retroactive to March 1st, 2020, CMS issued the fact that audio only is available, and that was a retroactive approval and will remain in place for the duration of the public health emergency. The claims filing requirements. So I listed the two CPT codes, well, the HCPCS codes for diabetes self-management training, individual and group. Now, another provision, as was stated, that diabetes self-management education is a lifetime benefit under the Medicare program. And as a lifetime benefit, it is a 10-hour benefit. That 10 hours is broken into 1 hour individual and 9 hours of group. But during the public health emergency, CMS is allowing for the entire 10 hours to be delivered as a one-to-one individual encounter. So now the person can have 10 hours of individual time when group sessions are not possible. And that includes a one-to-one session via telehealth. However, a provider can deliver group classes via telehealth using a group Zoom or an individual Zoom session. When they do that, they would code appropriately, either the individual code that is billed in 30-minute increments or the group code, which is G0109, that's also billed in 30-minute increments. Medical nutrition therapy, which is also often delivered as a companion to diabetes self-management education, is billed, it's a 3-hour benefit, and it's billed in 15-minute increments for individual sessions, and again, in 30-minute increments for group sessions. I mentioned already that the diabetes self-management training benefit is a 10-hour benefit with the 1 hour individual, 9 hours group, and again, that it can be provided. Now, diabetes self-management training does requires a referral from a provider to an accredited program that has recognition with the Medicare administrative contractor to deliver diabetes self-management education. So that's a key step in the process. First, an organization would get accredited, and they would seek accreditation either through the American Diabetes Association or the ADCES, American Diabetes and Clinical Education Group, used to be formerly AADE. And then they would submit proof of their recognition to the Medicare administrative contractor, which in Maryland is Novitas, and then they'll be formally recognized as a diabetes self-management education provider. I often get questioned about what about the beneficiaries that have Medicaid? Well, the challenge in the state of Maryland is that diabetes self-management training is not a covered benefit under Medicaid. However, as you all many know, that the MCOs, the managed care organizations, have discretion in covering benefits that are medically necessary for a beneficiary. And so that process requires the submission of the reason that a beneficiary needs a benefit that's not currently covered, and then you could obtain authorization to provide that benefit, but you need to check with the carrier. I've worked with many providers, and they've gone through this process of obtaining authorization from the managed care organizations, which then gave them a set of authorizations that they could use to bill for the services for a beneficiary that has Medicaid as a primary insurer in the state of Maryland. The claims filing requirements, you would submit, obviously, the rendering provider, the MPI would be listed, the HCPCS code, whether it's an individual or a group, and the place of service is equal to what the place of service would have been had that service been delivered as a face-to-face intervention, even though it's delivered via telehealth, along with the modifier. Institutional claims are billed using the GT modifier. So the process details, the appointment would be scheduled as either an individual or group. The individual would be invited to participate using the appropriate telehealth platform. The service would be delivered. It would be coded as an individual or group encounter. If it's a non-institutional provider, you would use the modifier 95, and the place of service would be what would be the place of service if it had been delivered as a face-to-face intervention. So let's say I'm a provider as part of the Maryland Primary Care Program. I obtain accreditation, and now I deliver this diabetes self-management education to a beneficiary that has a diagnosis with diabetes. I'm the clinician or staff of the clinician, and I'm in my home. The beneficiaries in their respective home, I would list the code. If I did it as an individual counter, it would be G0108. I'd list the place of service as the clinic setting where I would have delivered the service if it had been delivered as a face-to-face intervention, along with modifier 95. I think this just highlights again the fact that for the duration of the public health emergency, the services would be delivered, can be delivered in the home, and you would use the appropriate codes. The reimbursement rate is the same, even if that is delivered as an audio only. The only difference in terms of a regulatory standpoint is that there's not a special code that's submitted for the delivery of the service via telehealth, but ADCES, formerly AADE, does recommend that if you have their accreditation model, you do change one of your delivery sites to the home setting. Now, as it relates to Medicare and the Medicare administrative contractor, which is Novitas for the state of Maryland, you do not have to list your home or the beneficiary's home as an official delivery site for clinical services, because again, the place of service is the place of service that would have been had the service been delivered as a face-to-face. And this is again for the duration of the public health emergency. One thing to point out is many programs, in order to attain sustainability, it really is a volume business. So it's very important to drive as much volume as possible. And the ways that organizations that are delivering diabetes education can maximize the volume is by aligning those programs with clinicians that are taking on risk-based contracts. So as the entire health system begins to move to more of a value-based purchasing posture, then those organizations that are seeking to improve clinical outcomes and reduce the total cost of care may seek out assistance from organizations that can deliver evidence-based interventions to improve outcomes and reduce the total cost of care. As Dr. Peters pointed out, a diabetes self-management education program that follows an accredited model that adheres to the 10 national standards for diabetes self-management education is proven to improve outcomes and reduce the total cost of care. But unfortunately, most beneficiaries with diabetes don't take on those programs. But unfortunately, we've seen a big uptake where there's complications of diabetes, such as the proliferation of dialysis centers and other things where we're seeing more complications, but not enough education and prevention. The Diabetes Self-Management Training Program is a perfect venue to increase prevention to help with the management of the diabetes. Financial sustainability models also includes incorporating multiple programs to expand the delivery of education. As I said, this was a volume business. So establishing programs that can deliver diabetes self-management training, medical nutrition therapy, and you may consider diabetes prevention program. So under one umbrella, you can provide a range of interventions to address the full continuum of diabetes. I work all around the country, and one of the programs I was working with was in Seattle, and I noted that they were delivering diabetes prevention program, but 50% of the referrals they were receiving from that site, Swedish Medical Center in Seattle, most of those referrals, or 50% of the referrals, were for persons that had already converted to diabetes. So I just simply assisted them with, well, since you're seeing 50% of the referrals that are coming to a diabetes prevention program are for people who have diabetes, if we have both service offerings, now you've diversified your revenue stream, you've increased your ability to obtain sustainability, and you have more billable services that you're able to deliver based on the referral pattern. So that's just an example of how opening up the service line, still in the realm of diabetes, can enhance your sustainability by increasing your ability to deliver more services that are completely reimbursable. Also looking at multi-payer models, this is an established benefit for the Medicare program. So any beneficiary with original Medicare, this is an eligible benefit. Looking at where they have a 10-hour lifetime benefit with refresher training benefits that refresh every year. So someone generally always have diabetes education benefits on the books. And this is a mandatory benefit for Medicare Advantage plans. So looking at who are the Medicare Advantage plans in my market, that data is publicly available on the Centers for Medicare and Medicaid Services website. So you can see the enrollment by payer, by county, for every county in the state of Maryland. And that is the population that you could also begin seeking contracts with to deliver diabetes education. I gave the example around Medicaid managed care organizations, or MCOs, where there's multiple examples where organizations have worked with some of the large, well-known Medicaid MCOs. They go through a prior authorization process, and they're able to get authorization and then deliver diabetes education to a Medicaid beneficiary that's also reimbursable. So looking at ways to increase your referral volume, diversifying your revenue stream, and also having diversity in the payer sources that you accept all lead to sustainability in a much more advantageous manner. Thank you so much.
Tim, thank you so much for that presentation. I will say, for those of you who are getting CMEs, quizzes absolutely, in terms of you know, the CPT codes that are going to be used, and all of the various ins and out of it, as well as how to utilize CRISP. No, I'm kidding you. You're not going to have to answer those questions, but hopefully you will utilize. We are recording these, and we would love for you to be able to use them as a resource moving forward. So now I'm going to introduce Mr. Stanley Campbell. He is the head of EcoForce Associates and EcoForce Health. He has a background in physics and mathematics. Is a former Navy pilot. We've got other veterans I know represented here on the team. And he has patent submissions in business, intelligence, security, and healthcare arenas, including big data management and predictive analytics. So, Mr. Campbell, I'm going to turn the mic and the video over to you.
Well, thank you, Sue, and thanks to all of you for joining. Dr. Langley laid out the formation, and Dr. Peters actually gave us very good insight on the parameters associated with education and self-management of the disease. And I think Tim did a great job of basically identifying the money. So what we'll do, and I'll reference CRISP a little bit later in the briefing, what we wanted to do is to define and show a platform, if you will. You can go to the next slide, please, or if I can manage it myself. Do the next slide. Where within the confines of the platform, we have the ability to do remote patient monitoring and alerts. We also, within the confines of the platform, have the ability to do take and receive referrals from CRISP. So diabetes, self-management of disease, hypertension, congestive heart failure, COPD, all those are available. Within the confines of the platform, we're able to also take devices, and as the structure of this medication and immunization management platform is presented within the rest of the confines of the slides, we'll actually show those elements associated with not just medication and immunization, but diabetes, self-management of disease, nutrition programs, how the bridge between the clinician and the community health workers, and how the value proposition is Dr. Peters referenced, is quite well evidenced. And so as we go to the next slide, we'll get into some of the details associated with devices. So clearly we understand that telehealth is here and it's here to stay. Within the Mcneil platform, we actually have a partnership with Zoom, and we have one of the largest, if not the largest group platform structure, because our work is generally nationally inclined, where our core business, we support over 128,000 NDCs and 260 million Americans where their medications run through our systems. As it relates to that same platform, however, when we look at those things that were challenges to diabetes management, as an example, when COVID hit, those who are socially isolated had to depend on telehealth as their only health in some cases. And so as we look at the challenges that Tim referenced, the ability to just use a phone to do diabetes management, that's quite important. However, it's equally important that you're actually able to see that patient, to record that information. And if you're building these technologies in a sustainment model that will survive post-COVID, it is critically important that we actually try every effort to move to platforms that are HIPAA compliant. What we've done within the confines of Maryland, and as well we're now offering nationally, is the ability to provide a tablet or a phone at no out-of-pocket cost. One of the things that's referenced in the slides that you reviewed from Tim is that when you put the COVID modifier, obviously the patient has no out-of-pocket. So this is the time now to, if you've got that patient who is isolated, to get a phone. Now, the phone or a tablet device. Those phones or tablet devices are not restricted like the FCC phones, which are generally focused at Medicare and Medicaid patients. They come to the patient with the first 24 months paid. They come to the patient with unlimited talk, unlimited text, and unlimited data. So those things that go along with diabetes, like the social isolation issues associated with any chronic disease, the mental health and challenges associated with any chronic disease, diabetes is no different. I can tell you from personal response, where my mother had diabetes and received multiple issues associated with that, referencing from everything from associated to heart disease, and as well amputations that tie back to, I would say, things missing from like medication management therapy or like nutrition management. And those are the kinds of things that these devices and those that cover remote devices provide a very well extension to both the clinical training and as well as the community health training that is associated. All of these are billable, as you saw, within the confines of Tim's presentation. To the next slide, please. So what does that look like? Telehealth and those courses might be preloaded onto the system. They may also include a nutrition management, and as well give us an ability to interoperably connect both the devices where you might have the meters, you might have a blood pressure cuff, you might have a scale or Fitbit, all those things that move from the management of the disease to the healthy management of the disease, where we can actually incorporate those things as related to mobility and behavioral health. Unlimited talk, text, and data, while we're all socially isolated for COVID, the importance that we found was that as those patients are able to communicate, we don't care really if they're streaming Netflix all day. It really does not matter for the next 24 months, because as active as we can get them, the importance of providing these technologies and capabilities. And we often get the question of, well, what happens when I have an elderly patient like the one you see in the picture, which might not be computer savvy, if you will? Well, first thing, our first response is the community health worker, the clinician, and as well the family members themselves oftentimes have an interoperable care team, if you will, in which every chronic disease patient is now being trained or educated on those confines of telehealth and telemedicine. When we look at every course, be it diabetes, hypertension, congestive heart failure, COPD, and any other self-management training, what we're now seeing is that those community health workers and those clinicians are all taking the extra time to put a few minutes in, not just for the initial training of the patient, but as well to get them with repeat training as it relates to reminders of how to the interoperability and information sharing functions. And just remember, with that COVID modifier, there is no out-of-pocket cost to the patient, so that all the diabetes self-management programs that can actually be added to the confines of the system can actually be onboarded And as well, because these are now remote, we can also update when there's additional new programs that come into play. We can go to the next slide. So I think Tim did a great job of discussing the billing functions associated with this. So I won't go through too much of that, but it's one thing to remember, or at least to note, that any of these systems, and the MemeRx is one of those, when you're onboarding them onto a system that ties itself to persistent monitoring and self-management of disease, there's a billing code of where the average cost nationwide is approximately $21 per provider. So this is, and based on the 1135 waiver that was referenced, and as well the advent of the fact that we're in the emergency condition, you can do a 3-year look back on your patient population. So whether you've seen that patient in the last 12 months or not, your ability to do a 3-year look back and to onboard all of those patients that are in your profile and receive $21, as you then now have enabled your environment, your telehealth, your association with CRISP and the others to be able to now execute a HIPAA compliant telehealth visit. All of those become the value propositions for which going onto this platform or any other platform doesn't have to be a MemeRx, but it could be anything that actually gets you to a competent infrastructure that is augmented or augmentable by the HIE and the EMR. That becomes the ultimate in value proposition, and I'm sure every one of the physicians and nurse practitioners that has spoken before me will attest. You can go to the next slide. So chronic care management and the collaborative behavioral care health management, all of those were eloquently presented in previous discussions. So I won't spend too much time on that. However, what we've done in Maryland, just as an example, is we work with Living Well Center of Excellence as a center of excellence, not just for Maryland, but for the nation. We work with Tim and Sue as they have helped us position both the technology such that they serve as the best, we call it in our house, the best sandpaper that any technology systems can actually, system developers can have. Because as they identify the rough edges or the things that might be tough for the nurse practitioner who has to go into the home, or that might cause angst with the paperwork and keeping up with the paperwork that is necessary for the billing structures to be sound and auditable, particularly when we go into the training side. Clinicians have for the most part, done an excellent job in this transition. The more difficult thing has happened with chronic disease management, where the community health workers are now themselves found kind of off kilter because they can't see, feel, and touch those patients. And so what the platform has done, and we feel comfortable that we've smoothed out all those rough, or many of those rough edges that occurred when COVID first hit, is that bridge between the chronic care management and the chronic care training. And by virtue of the fact that both the clinicians and the community health workers can actually see the patient's records, and as well the patient has their own mobile access to that information, so the self-management of disease then falls into place. And the core competency for diabetes is first, that food is the first medicine. And that second, that the patient themselves becomes the first clinician. And if we can actually empower that, that becomes the value proposition where chronic care, collaborative care, and tied to behavioral health actually move us into that next paradigm where the transition from fee for service to pay for performance actually brings the value proposition into those who are who are managing like Medicare patients and Medicaid patients. But the other good part about this, as we look across the nation, as we operate across the nation, these same elements are tied very closely to the commercial payers, and that they have now recognized or have long since recognized the fact that these behavioral and chronic disease management programs save them a lot of money, thus reducing their risk. And as we do everything we can to keep those patients out of emergency settings and presentation to the emergency room, those value propositions continue to extend. Next slide. So one of the programs that we are working within the community health worker side, meaning we spend a good amount of the discussion talking about the clinical side and the self-management side, is that social isolation. Diabetes patients and others actually have very often, like my mom, present with multiple morbidities. The good thing that, and one of the things that was clearly referenced is that these are cumulative billing opportunities where if you're seeing that patient for medication therapy management billed at 20-minute segments, quarterly up to 90 minutes, that becomes a very key value proposition for everybody who is evaluating that patient or who might have oversight of a community health worker. When we're looking at the effect of the disease, where that patient might go off their nutrition regimen or not manage their disease well, and that the social isolation then starts triggering in and kind of attributing to their movement off of regimen. Those become again the additive of components for diabetes self-management of disease that becomes critically important. And that even ties to those who are diagnosed with pre-diabetes and as well who are on path to diabetes, but for the fact that we might be able to intercede early. Next slide. So I'll actually sum up with the fact that these are technologies that have been brought and are actually featured in Maryland, where the MAC folks and I were just in Chicago last week, and they're working with a group that are dealing with diabetes self-management, and as well how that is impacting the areas that we normally on the news back east hear about, where there's heavy shooting and other negative impacts from disparity, poor, and socially isolated communities. But we also, during this same period, have seen virtually a large majority of the health system and the community health system in Florida virtually collapse because they had a lack of an ability to transition to sustainment models. One of the things that we're so proud of working with companies like Tim's and with people like Sue and the like is that as we look at these programs and we prepare them, prepare the patients, the community health workers, and the clinicians on the sustainment models are actually baked into those codes. The ability for us to bring on these patients and onboard them in a way that is extremely relevant, both for nutrition and diabetes management. Those have historically been difficult for billing purposes because our smallest folks can't afford the telehealth infrastructure. Our patients haven't been able to afford smart devices. We haven't been able to bring an infrastructure that creates a documentation trail where the billability, the sustainability, the survivability, and the security has been the all equally considered components. And so that's what we've tried to do. And the great thing about all of this is MemeRx is available for every patient in the United States in at least 8 different languages, and they can download that application at no cost to the patient. And so when we look at making smart devices available to these patient populations with no out-of-pocket, and making the infrastructure available to doctors for a small fee as it relates to what the new revenue that is coming to them, and then making a revenue stream for community health workers. That's been our mantra. And every day I look at these systems, particularly with diabetes self-management, I get the chance to think of my mother and how proud she would be of a system like this. So thank you all for your time and your attention. And I'm open to any questions.
Wonderful. Thank you so much, Mr. Campbell. And again, inspiring work, and we have this real opportunity to move forward. I'd like for all of our speakers to please unmute and to put their photos up. Welcome to everyone. I want to encourage all of you, please, to submit some questions into chat. I have 2 to start with. The other thing that we can do is you can raise your hand and we can unmute you and you can ask questions directly. I'm going to start with the 2 that I have now. The first is, and I don't know if we have the right folks here, this probably would be for Dr. Peters or Dr. Rabner, and that is, what are recommendations for flu vaccinations for people who have diabetes?
Everybody who has diabetes should get a flu vaccine every year. There is some concern and some caution, and it definitely merits a discussion about getting the nasal vaccination, vaccine for people who have diabetes. But I mean, that's something to discuss with your primary care provider. But everyone who has diabetes is actually in the priority category for getting a flu vaccine every year.
Great. Thank you very much, Dr. Peters. And the next question, I believe, would be for Tim, and that is, in order to bill for diabetes education sessions for my patients, do I have to register? Could you again explain briefly?
Yes, thank you. So the steps are, first you have to obtain accreditation, and that accreditation is through ADCS or recognition through the American Diabetes Association. Both are equally recognized. Once you obtain that, then you will receive a certificate. That certificate has the name of the clinician, the clinical practice, as well as a tracking number. That then certificate has to be submitted to the Medicare Administrative Contractor, which for Maryland is Novitas. At that point, then you have CMS recognition, and at that point, you can begin billing the Medicare program for reimbursement. Most Medicare Advantage plans adopt the same process. So initially, it begins with obtaining accreditation. Now, the 10 national standards for diabetes self-management education is the framework upon which the accreditation process follows. So you could do a Google search for the 10 national standards. You would deliver a program according to those standards. Then you submit for accreditation or recognition with ADA.
Thank you, Tim. So folks who are attending, if you have a question, if you can go into chat and raise your hand, we can absolutely get you on. And what I would like to do now, while we're waiting for that, is to just ask our incredible panelists if you had some additional thoughts that you would like to share in general.
I would like to sort of reemphasize something. As clinicians take care of people with diabetes, I mentioned it, but I wanted to make it a little bit more clear. So ideally, we would really love to have people who are diagnosed with diabetes get Dsmes. Make that the first thing that you offer that person, and really help them go and attend that class. But again, once that 10 hours, whether it's an hour individually or one-on-one, or during this very special time that we're all living through, you get all of those 10 hours, delivered in some other way. There's still a need for diabetes education and support. Diabetes is a hugely complicated problem, a clinical problem. So over the lifetime, that community-based programming, the community-based education that is not in front of a certified diabetes educator, but with lay people and with support of people who might live in your area and know where your supermarket is and know that you have, issues with sidewalks and that there might be no place to exercise. That is super important. It's really important for clinicians to encourage patients to go to those programs as well, because that's where you find that you can make bonds with people who share your situation, who understand what you're living through, who aren't wearing a white coat or a set of scrubs, and who aren't official medical people, and they can really be helpful. And I don't know that clinicians are familiar enough to know that these programs are really widespread, that they're very well supported in our state. And Sue, you can talk a little bit more about that if you'd like. And that they're important because they are personal ways of supporting people and people supporting each other through this very long journey of diabetes. So I think it's really important for clinicians to know that it's not just individuals out there doing their thing with diabetes once they leave the clinic. There are programs in the community that are very well supported, very well known. They have evidence behind them that they are helpful, and it's really important to encourage patients to use these programs.
Thank you, Dr. Peters, and you're exactly right. One of the important things about many of the diabetes programs, by the way, the diabetes self-management programs, is that they are open not only to the individual with the condition, but to family members as long as they're over 18. And certainly we've talked, again, we're doing these webinars with people in community with diabetes, prediabetes, and their family members, and we're doing webinars with direct care providers and community health workers. And absolutely involving people who are just like us. We all have that trust in our own community, those leaders in our community. And so it's tremendously important, I think, to do that. And I think, do we have a hand raised? Yes, so let me see. Go ahead.
Sorry, this is Swarup Rao, and a question for Dr. Peters is that how do I go about finding these local programs who know their grocery stores and curbside where the exercise can be done in their community? How do I go about finding them?
And Sue, you can also chime in here as well. And Anne, you can help with this answer as well. You can Google behealthymaryland.org. All one word, behealthymaryland.org, and there is on that website, which is there's a lot of resources on that website and a lot of different links, and that will actually help to give you an idea of some of the programs that are available by across the state. Also, if you Google the Maryland Diabetes Action Plan, the page on which the link to the Maryland Diabetes Action Plan appears also has an inventory which gives you a list by county of places that offer both diabetes prevention programs as well as diabetes management programs. And what's really interesting is that I had a conversation, I believe it was with Anne Langley, just very recently. It is important to think about sort of building a mental Rolodex, a mental index of these types of programs for the patients that you serve most. When we know who the orthopedic doctors are that we like to refer to. We know, who the dermatologists are that we prefer to send our patients to. it's important for us to sort of try to figure this out, and then try to keep that Rolodex in mind. The tricky thing is that for a lot of diabetes prevention programs and some of the diabetes self-management programs, it's hard to figure that out if you don't have a list that pops up in Epic, for instance. So using the resources that we have in Be Healthy Maryland .org and on the diabetes action plan inventory page are good places to start.
I agree. Thank you so much. And if you don't mind, can I ask one question to Tim Mcneil?
Sure, go ahead.
You said to Google about the 10 national standard study. What exactly is that?
Sure. So there's the 10 national standards for diabetes self-management, education, and supports. Those are the standards upon which a program must follow in order to get accredited. So you would use those 10 national standards as the basis upon which to structure your diabetes self-management education delivery model. Once you have done at least one test class according to those standards, then you're eligible to submit for accreditation. You could go to accreditation to ADCS, formerly the American Association of Diabetes Educators. You submit proof of completing at least one class according to those standards. Then they will accredit your organization. And you submit proof of accreditation to the Medicare Administrative Contractor, which is Novitas in Maryland. And then you're eligible to bill Medicare for the delivery of diabetes self-management education to those beneficiaries using the DSMT or diabetes self-management training benefit.
So this is for physicians and nutritionists.
Right.
Anybody who wants.
It's for any organization. That's correct. So it's
Thank you.
For physicians. It could we even have examples where community-based organizations have partnered with physicians and clinics to deliver that model. We have FQHC models, ambulatory health systems. All of those entity types follow the same process to first get accredited, submit proof of accreditation to the Medicare Administrative Contractor, and at that time they can begin billing the Medicare program and receiving reimbursement.
Thank you so much. Thank you.
Sure, and I also wanted to let you know that we have 3 area health education centers training community health workers in the state of Maryland. And they are all absolutely involved in all of this work and doing special trainings. Again, we require an incredible number of hours for training for community health workers. So that's another place that you could go. There's one AHEC West, there's Eastern Shore AHEC, and then Maryland Central AHEC in Baltimore City area. So those are places that if you wanted to think about hiring or utilizing the services of a community health worker, those would be there as well. I want to continue to remind people, if you have any other questions, to ask us in the chat. Also to remind you that it's tremendously important that you complete the brief survey and evaluation at the end of the webinar. Again, you need to do that in order to get CMEs or certificates of attendance. But most importantly, your feedback, as both Anne and Sadie said earlier, is really critical to how we move forward over this 5-year plan to make sure that we really do change the way that diabetes is managed statewide.
So can I just take a second to talk about the resources? I mean, everything, I agree with everything that Sadie said. And I in my previous role at Hopkins, I had so many conversations with physicians who very understandably were distraught. They said, I can't possibly know all the churches that have exercise groups, all the places that are distributing food this week, where the latest cooking class in a church has cropped up. I mean, and these resources are very local, and they are constantly changing. And there are lots of sort of jokes out there about community health workers and whether they'll share their resources or not. It's always been a very prized resources. And I'm hopeful, and I don't think all of these connections are there yet, but by really advocating for your patients to get to a DPP program or to Dsme or to DSMT, I'm hoping that that's a gateway for them to then find some of these other resources. That, or that you have a great community health worker in your practice, which I also think is really increasingly important. But I know that it's not always a resource that you have. But you know, if you made your priority to get to those other programs and encourage patients then to look for the rest of it, there are lots of experts out there, like Sue said, the community health workers at the AHEX, or you know, there are lots of other ways to connect to those local resources.
Thank you, Ann. And we also on the first webinar, and again on the last webinar, which is a week from today, same time, same place, are going to be talking again about those connections with area agencies on aging. Again, there's one in every county in the state. Local health departments, another good resource. So there really are an incredible number of resources that are available. We just have to figure out how to work together and to really connect to make this work.
I want, if I could just piggyback on Dr. Langley and Dr. Peters, and as well Tim. One of the things you want to recognize is the fact that Tim referenced how you get certified and how you get your courses certified. However, there are a number of entities that are already certified that as a clinician, you can make the referral. So if you're in your EMR and and that EMR has access to CRISP, you can actually make that referral through CRISP. And that community health entity can actually receive that referral. And it's not like you're handing off your patient. What you're doing is building the care team. And as you build that care team, it becomes almost like a tennis court where the volley from the community health worker volleys over to the doctor and vice versa. So that team actually starts working together. The last point on that is that then creates a billable track in that the doctor who refers that over still maintains oversight over that community health worker. So that person who is local, who is knowledgeable, who is in pretty much the same ecosystem as that patient, who is doing the training, actually still gets the oversight from the clinician, and the clinician gets a better view, more touch points, because that information is all available to them. That becomes, that volleying back and forth becomes why Maryland happens to, I think, lead the nation based on the fact that it has an HIE infrastructure that is tied to the community health workers, and that things like the AAAs are already now knowledgeable. And as we can get our primary care physicians on board with that knowledge, and as well the hospitals are already there, we actually have, as Dr. Peters referenced, that ecosystem that really should drive the nation to standards that just aren't achieved in other places that we operate.
Great, thank you very much, Stanley. I appreciate that. Wonderful panel, tremendously important information that you've all shared. I thank you for your time. I certainly thank all of you who attended for your time. I know you've already had a full day, and to stay with us for an hour and a half is asking a lot of you, but certainly hope that you've learned wonderful things. Hope you will join us next week, same time, same place, for referring to an endocrinologist, new medications, and more. Thank you, everyone. Have a good night and stay safe.
Thank you, Sue.
Thank you.
Thank you, Sue. Dr. Langley.